Good evening, everyone. We'll be getting started here in just a few minutes. Good evening, everyone. Welcome to Wu Yu Keratoconus Review and Surgical Treatment Update, CXL, Topo-guided PRK, and CAIRS with Dr. Evan Schoenberg. Thank you so much, Dr. Schoenberg, for being here tonight with us. Super excited to learn from you.
Glad to be here.
Next slide, please. I'm your host, Elise Kramer, currently in Miami. Where are you connecting from, Dr. Schoenberg?
I'm in Atlanta, Georgia.
Awesome. Not far, not far. Next slide. So thank you to Glaukos for providing an educational grant to support this event. Now, we do have some poll questions. These questions are really important. They allow us to have educational grants from these amazing sponsors. So please take the time to answer the questions. And after that, we can move on with our amazing presentation. Great. Next slide, please. Thank you so much for taking the time to do that. So for each hour of CE units, attendees must be online for a minimum of 50 minutes. This is a 1 hour presentation, so you must be on for a duration of 50 minutes in order to receive COPE certificate. There will be a survey link in the chat. Also, the survey link will appear when the webinar ends. CE certificates will be delivered by email and sent to ARBO with OE tracker numbers. There also is going to be a QR code at the end of the event, but you do need the OE tracker app on your phone in order to get CE. If you don't have the OE tracker app, it's not a big deal. You'll still get the CE certificates by email within 4 weeks. Again, you can't just use your camera on your smartphone. If you have any questions for our amazing presenter tonight, you can use the Zoom on-screen floating panel. Keep the chat for any logistical questions for our team. If you have questions for the doctor, please use the Q&A. We will go to the questions toward the end of the presentation, time permitting. Next slide. If you're using the mobile version of Zoom tonight, you're going to see Q&A is going to be at the top. If you do have any logistical questions and want to write in the chat, you can click on those 3 buttons at the bottom, or 3 dots at the bottom, and you'll have more options, and then you'll find the chat there. Next slide. And I will introduce our speaker, Dr. Evan Schoenberg, who is a board-certified fellowship-trained ophthalmologist who specializes in vision correction, including cataract surgery, LASIK, PRK, ICL, and lens exchange, advanced corneal transplantation, corneal crosslinking, and management of complex corneal disease. Wow. He has been recognized as one of America's top 100 ophthalmologists by Newsweek and locally as a top doctor by both Atlanta Magazine and Castle Connolly. A summa cum laude graduate of Vanderbilt University in Nashville, Tennessee, with a bachelor in neuroscience and a minor in computer science, Dr. Schoenberg earned his Doctor of Medicine degree at Emory University. He then completed a medical internship of ophthalmology residency at Tulane University in New Orleans, where he served as chief resident. Following residency, he completed a fellowship in corneal transplantation, refractive surgery, and external ophthalmic disease at the prestigious Price Vision Group in Indianapolis, Indiana. He serves as co-managing partner at Georgia Eye Partners in Atlanta, Georgia, where he also leads the refractive keratoconus clinic. His other passions include his wife and 2 children, artificial intelligence, tennis, running, scuba diving, and wine. Wow, amazing. So glad again to have you. I will be back on later for questions. And in the meantime, I can't wait to hear what you have to teach us tonight.
Thanks very much for that kind introduction, Elise. So, as you heard, I'm Evan D. Schoenberg, MD. I'm a cornea cataract and vision correction surgeon at Georgia Eye Partners in Atlanta, Georgia. And I'm thrilled to get to deliver the introductory lecture on keratoconus. Because in 10 years, I hope it'll be very rare to find ourselves here. It is a photo that I took actually with my iPhone, hashtag shot on iPhone, in the OR at a nearby hospital here in Atlanta for a patient we were about to do a penetrating keratoplasty. And what we're going to talk about tonight is the reason that transplants like these are on the decline by 50% in the last 10 years. And I'm hoping we get another 50% decline in the next 10 years, thanks to folks like all of you in the audience recognizing and treating or helping us treat this disease. But first, a family story. So in January 2015, my brother Joel and my then sister-in-law Leslie flew to Atlanta with a plan for them both to receive LASIK so they get out of those glasses that you can see them wearing as we went into that weekend. We're seeing them in clinic on Monday for a LASIK surgery on Wednesday. Leslie came in as a pretty typical mixed astigmatism, 20/20, best corrected in both eyes, totally normal exam. These are her orb scans, which is an older technology we were using at the time. We've now upgraded to a Pentacan, but these provide very similar information. A topography, which you see in the bottom left of the screen, along with information on the front and back surfaces of the cornea, top left and top right, anterior and posterior float, and a pachymetric map. Her scans were totally normal in the right eye, also in the left, showing symmetric with the rule astigmatism, a regular bow tie in each eye, consistent with her refraction, totally healthy, and a great candidate for LASIK, which we performed. She was 2015 on day one. She stayed 2015 in the nearly 10 years, actually right at 10 years since then. But Joel was a different story. He had similar, actually uncorrected acuity hyperopic astigmatism, 2015 and 2020 -1 best corrected respectively, and a normal slit lamp exam except some mild dry eye. This was his orb scan for the right eye. That keratometric map, the topography in the bottom left of your screen, looks relatively normal, but there's a little bit of inferior steepening. By itself, we might think this was a lid artifact or an artifact of an elevated tear lake, wouldn't make much of it. When I looked at his left eye, I knew that we were not doing LASIK that week. Because what we see here is a classic picture of keratoconus. That top right image of the posterior float shows an elevation on the posterior cornea associated with the pachymetric map showing thinning in the bottom right and substantial asymmetric inferior steepening on that topography in the bottom left of the screen. Joel's assessment was early keratoconus with mild dry eye. I said, we're not doing refractive surgery this week. Let's treat your dry eye because some masquerades can happen and reassess in 6 months. This was his first scan, first thing we knew about him. We're going to consider cross-linking if we see any signs of progression. So Joel came in May of 2016. I'd said 6 months because my brother and other things got in the way in terms of life, so it was a year and a half instead of 6 months. Unfortunately, now his left eye has gone from 20/50 to 20/70, and we see a half diopter increase in astigmatism in the left eye. Still, the slit lamp exam looks pretty normal. This is his topography. In the top left, we see from January, the bottom right is May 15th, and you can notice that there's an increasing amount of that inferior steepening. So what's going on here? Well, this is keratoconus. It's a long described disease, first discussed in 1736, the subject of 270 pages by Dr. Nottingham in 1854. And here we are over 100 years later, 150 years later almost, and we still don't fully understand the disease. But what we do know is this. It's a primary ectatic disease, progressive, bilateral, central or paracentral ectasia, associated with corneal thinning at the apex, which is the peak of the cone, typically central or infratemporal, and it induces irregular astigmatism, increasing myopia in most cases. Note that Joel was atypical, having hyperopia, scarring, or eye drops. It's generally considered to be non-inflammatory, but as we'll talk about in a little bit, there are inflammatory aspects of this disease. And while it's not purely environmental or purely genetic, there are components of both. Epidemiology is likely underestimated by studies which quote 0.05 to 0.23, but I think the real incidence is actually likely higher than that. Adult onset is early puberty. Mean age of diagnosis is 23 years of age, and we tend to see a progression into the 30s or 40s, and then it stabilizes or evens out. And there's a moderate male over female predominance. Some populations have a much higher rate of keratoconus. What these conditions all have in common, Down syndrome, Ehlers-Danlos syndrome, Marfan syndrome, is issues with connective tissue disease. The Down syndrome effect is usually magnified by the environmental aspect of rubbing the eyes, which these patients often do. Rubbing, therefore, is a big important thing to think about, not just in folks with Down syndrome, but in most of our keratoconus patients. So there's a huge association between keratoconus and atopy. Atopy, rather, is a form of allergy where hypersensitivity reactions occurring in a part of a body not in direct contact. So this is like you were to get pollen on your skin, but you sneeze without the pollen getting in your nose. That's not exactly what happens in these conditions. But the point is, the allergy happens at the eye, even though the allergens are happening elsewhere in the body. There's also associations with asthma. What this means is that these patients may have a connection that is genetic, keratoconus associates with it, or maybe the behavior of the eye rubbing. And certainly in several analyses, eye rubbing has been strongly associated with keratoconus. So an intervention we can do for our patients who have keratoconus is instruct them, stop rubbing your eyes. That alone can reduce the risk of progression. It's not enough, but it's a start. So most of these patients that I see who have keratoconus, I end up recommending they start an anti-allergy drop, an antihistamine topically. This can reduce their propensity to eye rubbing. I tell patients, look, this is going to help you have 80% less itching. The last 20% is going to be on you. The theory of what's happening, this is that connection back to inflammation I mentioned, is that interleukin 1 is released during epithelial microtrauma, which is to say eye rubbing. And we find that if you examine the cornea that has keratoconus, let's say specimens taken during transplantation, they have 4 times the concentration of IL-1 receptors. So IL-1 is being released, and in keratoconic patients, there's an increased sensitivity to that IL-1. What IL-1 actually triggers is a process of cell death, apoptosis, which in turn means that when the people are rubbing their eyes, they're literally instructing their bodies to kill off their corneas. Very concerning. Treating the source is very important. Let's look at the slit lamp for a few minutes. Now, by the time that you see keratoconus at the slit lamp, we wish we diagnosed it years before. But it's still important to recognize these classic signs. The conical cornea with apical scarring is really not subtle in many cases where they're advanced, but can be seen in earlier cases that are more subtle. The void stria, again, are a moderate to late finding. They're the stretched lines that are seen in the cornea as it deforms. The Fleischer ring is another chronic finding because as the tear film distributes across the cone, it leaves iron deposits at the base of the cone. That's why it's a curved ring outside that central cone. The Rizzuti sign and the Munson sign, again, late findings that we find as the cone is substantial enough to be seen from the side or to even deform the eyelid when the patient looks down. And if you're doing retinoscopy, you can notice a scissoring of the light reflex. This would likely be seen sooner than the other findings that we just described because it's actually more of a refractive finding than a physical finding, but it's still something that's likely to be late in the course of disease. And how often are you really retinoscoping these patients? So the slit lamp has minimal early role for these patients. Loss of visual acuity is a late finding. Topography is key. Epithelial thickness mapping is also a useful early tool, but not commonly available. And if you don't have topography, refractive change and asymmetry between the eyes can also be key findings. So let's look at some topographies. These are normal topographies. In the bottom left, we have a normal bow tie astigmatism with the rule, much like you saw in Leslie's scans before her LASIK. The 2 scans in the top right are symmetric bow tie astigmatism with an oblique pattern. But these are all abnormal findings. The inferior steep pattern typically isn't very subtle, but the symmetric bow tie with a skewed steepest radial axis can be much more subtle. Here we see that the top and bottom of that bow tie have about the same keratomatic values, but the bow tie, instead of being straight up and down, has a skew to it. It goes up and then off to the side, and that's a keratoconic topography. An asymmetry between the inferior and superior cornea is also a common keratoconic finding. 1.5 diopter difference in that mid-corneal area is the usual threshold we think of as abnormal. You can also see the same thing in reverse, a superiorly steep bow tie, having to do with usually the location of the cone. And there's various combinations of these, like the asymmetric bow tie and the junctional pattern and the claw pattern, which is classically taught in the textbooks as being pellucid marginal degeneration, but can absolutely be keratoconus as well. So tomography can distinguish keratoconus from normal, also keratoconus from pellucid. And what we're seeing here is a pentacam, our modern imaging system. In the top left is a topography, inferior steepening. The top right and the bottom right in this image show the elevation front and the elevation back. These are sometimes misunderstood as representing the actual cornea, but they're actually the cornea relative to a best fit sphere. What that means is that for any given cornea, the system calculates a theoretical sphere that's as close as possible to the shape of that cornea, and then shows at each point the difference between that sphere and the cornea. We don't expect these numbers to all be zero because no cornea is truly spherical. But in a keratoconic cornea, there's a hot spot, a zone that rises above that sphere faster than everything else. And here we see that plus 55 microns in the bottom right. That's the elevation lifting closer to the anterior surface than that best fit sphere. And in the bottom left, we have a corneal thickness map. This is showing not just the thickness in one spot, but in every spot that's scanned. And typically in keratoconus, we have thinning at the apex of the cone, which is typically infratemporally displaced relative to the corneal center. Here's a more severe keratoconic, same thing, but more so. And we can also use a computerized analysis of the pentacam called the ectasia analysis, which is very helpful. This puts numbers to help us just quickly assess the risk of ectasia or the likelihood of keratoconus in a virgin eye. It also shows these front and back difference maps, which compare the whole cornea float to a float excluding the central 3 millimeters. And these provide very visual tricks that we should look into more detail for the presence of keratoconus. Final D value in the bottom right is of most prognostic value. So this is a more subtle cornea. This cornea seems to have oblique astigmatism. And if we just looked at a topography, we would think this was a normal cornea. But as you look at the tomography, as you look at the elevation on the backside of the cornea, this shows a substantial elevation in that infranasal zone, an atypical spot for keratoconus, but still seen, and an inferior displacement of the thinnest part of the cornea. This is the reason that when you have a patient you're suspicious of keratoconus, having a topography is very important, but having just the topography may not tell the full story. And if you're working from this might be a trigger to send to your local cornea specialist for further evaluation. If, let's say, this patient had increasing astigmatism, increasing myopia, decreasing visual quality, or things just didn't quite make sense. Now, this was the scan that we saw as the four-map refractive. When we go to that ectasia display on that same scan, it gives us that 2.91 in the bottom right corner, flagged with yellow. It says, hey, this is probably a suspicious cornea. Let's think about it, watch it more closely. There are other diagnostic tools as well. The most interesting of which is sort of an up and comer in the world of keratoconic diagnostics, is the pachymetric map of the epithelium. So you get the pachymetry map, you get the epithelial thickness map, you look at both of them, and you're looking for a hot spot where the epithelium is abnormal. It turns out that epithelium changes in response to subtle stromal changes before the topography, before the posterior float, even before the refraction changes, as the body tries to account for what's going on. If you don't have a topographer, look for steep Ks, high astigmatism, a changing refraction, or a family history. I'm not going to spend long on non-surgical treatments. Many of you in the audience are much more expert on this than I am, but as we know, scleral lenses have been absolutely magical for the vision for people who have keratoconus. In fact, I will never graft or regraft a patient in the setting of a clear visual axis without trying or considering a specialty contact lens. And they're not a contact lens failure if they've just tried once. We need someone who is skilled in fitting, is patient with the patient, gives them a fair shot at it. But it's important to remember that lenses are not disease modifying. And this is where our excellence can get us into trouble. You can have someone seeing 20/20, but their keratoconus is progressing beneath that contact lens. And that's where cross-linking comes in to allow this patient who might be dependent on contacts to remain visually successful in the contacts in the long term. We have surgical options to replace the cornea, like deep anterior lamellar keratoplasty and penetrating keratoplasty, but I do very few of these for keratoconics in my practice. I prefer to reshape the cornea when possible and halt progression. Our options to reshape the cornea include topography-guided surface ablation, or PRK, and CAIRS, now often called CTAC as well, a successor to INTACs. Neither of these prevents fitting into a scleral contact lens for the absolute best vision, and neither will give vision as good as a perfectly fit scleral, but they may be much more convenient, and many patients are excited about that option. If the patient's perfectly happy in their scleral, we can keep using the scleral and just cross-link. And that's where cross-linking comes in as locking it in. So cross-linking is key for every progressing ectatic cornea, unless a transplant is intended. So what is cross-linking? Cross-linking is the only procedure proven to halt the progression of keratoconus. The mechanism of cross-linking is that a photosensitizer, vitamin B2 or riboflavin, soaks the cornea, maybe mixed with various additives to change its properties. For example, 20% dextrin. This reduces swelling of the cornea while it's being exposed to it. The goal is complete saturation of the cornea prior to the final phase of treatment, which is the UV treatment. Now, riboflavin is a large molecular weight molecule. What that means is it cannot penetrate an intact epithelium without help. There are a variety of approaches to that, the most straightforward of which, and the most well-proven of which, is the epithelium off technique, in which we simply remove the epithelium to allow that riboflavin to soak into the cornea. Every epithelium on technique that's been explored either is a sham treatment by not getting past the epithelium, or is doing something clever to get past the epithelium with varying degrees of success. We'll talk more about that in a few minutes. In the bottom right here, you see a cornea being held by forceps. The bottom cornea has not been cross-linked, the top one has. You can see how that one can actually resist gravity. The result is a 3x strengthening in the corneal fibers themselves. So remember Joel? We started our conversation with Joel. October 7th, 2016, he's continued to progress with increasing astigmatism while we've been working to get him in for the time that I can actually do the cross-linking for him. So cross-link the left eye. After discussion of all the options, we chose an epithelium off approach and performed the procedure as such. Remove the epithelium. I prefer a device called the EpiClear, which is by Orca Surgical, no financial interest. This allows a very clean epithelial debridement, but there's also other techniques like alcohol-assisted or a hard to say, the brush, you know what I mean. The second stage is riboflavin soaking the cornea with vitamin B2, verifying the riboflavin saturation, and then finally treating with the UV light. The post-op of this procedure is, in terms of drops, very similar to what I do with a cataract surgery typically, a 4-3-2-1 taper over 4 weeks. I use a combination prednisolone, gadafloxacin, and dipephenac. We remove the contact lens around day 5, just like after a PRK. And follow-up is typically scheduled at months 1, 3, 6, and 12. We do serial topography, tomography, and refraction, and we expect the vision to return to baseline over the next 6 weeks or so. Co-management is very much possible with this patient, this procedure, in terms of the care. However, the procedure itself is not eligible for co-management. It has a 0-day global period. What that means is that after the surgeon performs the procedure, each subsequent visit, even starting from day 1, is a regular established patient visit and can and should be billed as such. If you see the patient for a 1-week follow-up, which is the first follow-up I typically do after cross-linking, you would see that a bandage contact lens is in place. You're going to remove that bandage contact lens, and ideally the epithelium is intact at this point, although it may not yet be fully smooth. Go over the drop schedule for the patient, talk about tapering it over time. This is very similar to what you do with PRK. Vision will be worse for at least the first month. This is not only because of epithelial remodeling, but also because of some transient haze in the anterior cornea. And I'll show you some images of that in a few minutes. And you may see a hyperopic shift as the cornea flattens. Complications are rare, but it's worth being aware of them. The most common complication of epithelium off cross-linking is slow epithelial healing. These are images of one of my patients at 1 week post cross-linking. You can see the fluorescein-stained epithelial defect right at that apex of the cone, and it's visible even just with sclerotic scatter. This is the most classic place to see slow epithelial healing, and usually it's while the patient still has the BCL in the eye. These are not contact lenses that are fit for keratoconus. They're just regular soft contacts. And so they may be rubbing the apex of the cone. A persistent defect at week 2 can be managed by removing the BCL and lubricating aggressively. If the patient doesn't already have punctal occlusion on board, I would definitely add it at that point. And they tend to start healing pretty quickly at that point. This patient, a week later after removing the BCL, had a healed epithelial defect, still a little bit of epithelial remodeling, which continued to gradually improve over the next several weeks. Notice the slit lamp image. You can see it on the left side. The anterior cornea has a haze which extends to about 30 to 40% depth. That is not a complication. That is totally normal, and that's actually called the demarcation line. That's the depth to which cross-linking has occurred, and it fades over the first month and a half to 2 months. And that's the reason why, even if everything else looks normal, patients will tell you at month 1, everything's just a little bit hazy still. At week 2, they can resume contact lenses, but remember the prescription may be off, the fit may be off. I tell my patients, please listen to your body. If it's not comfortable, stop wearing it. Between month 2 and month 3, a motivated refit can be appropriate, but warn the patient there may still be changes coming. And at month 6, maybe the ideal time for a refit, but there still may be changes coming. So does cross-linking work? Yes. Over 400 peer-reviewed articles have said yes. Let's look at what Joel's results were. So this is the most recent topography I have on Joel from June 2023. You can see that he has a stable topography, stable refraction, stable best corrected acuity over this period. We're planning the CAIRS procedure for him soon, which you'll learn more about later in this talk. So epithelium off is the form of cross-linking which has been studied most extensively. We have well over 10 years of follow-up. Long-term studies show continued improvement, even up to 4 years and up to 7 years. Beyond that, there may be continued improvement. We just don't have all the data for it. Long-term stability rates are excellent. every epithelium off study has shown high rates of stability, and 85% of treated patients have no further progression. That, by the way, is from a 10-year follow-up study. Visual acuity tends to show a modest or mild improvement in uncorrected and best-corrected acuity, a little bit of a decrease in higher-order aberrations. Generally, patients get no improvement to 2 lines of improvement. And so when we talk to patients about expectations from cross-linking, we definitely want them to understand this is not a refractive procedure, it's a stability procedure. This was the phase 3 study that led to the approval of iLink, the glucose cross-linking system, which is the only FDA-approved system for cross-linking in the United States. Avedro is the company that owned the system prior to glucose purchasing it. So that's why it's the Avedro phase 3 study. And what we see here is that cross-linking in blue showed a progression of improvement from baseline to the 12-month mark, while the controls showed a worsening over the same time frame. So it's really to quote the movie Dodgeball, a two-man swing. We're getting improvement in the people who get treated, and we're avoiding the worsening of people who didn't get treated. Here's another study using the same protocol, the Dresden protocol, doing 3-year follow-up, published in 2014. So very long established information, which has only gotten more established since then, showing that cross-linking at year 3 had a 1.2 diopter flattening effect versus 1.8 diopters of worsening in those who didn't receive cross-linking for a net benefit of approximately 3 diopters. We've mentioned the epithelial risks of cross-linking. There's some other theoretical risks we see very rarely. Corneal haze can sometimes form. Sorry about that, guys. Corneal haze can sometimes form just like after PRK and can be treated with topical steroids or topical losartan. If there's a LASIK flap, it's important that the surgeon be aware of that LASIK flap and not inadvertently disrupt it when removing the epithelium. There's theoretical risks of collateral UV damage, though I've never actually seen that in the 11 years that I've been performing cross-linking. So we recommend cross-linking if the stroma is sufficiently clear to support good vision, there's a reasonable expectation of glasses or contacts providing acceptable vision after the procedure. If those 2 criteria aren't met, consider a transplant. Any young person with progressive, mild, moderate, or severe keratoconus and best corrected of 2025 or worse deserves cross-linking, and 2020 should be considered as well. Excuse me. Very sorry, team. I needed to cough, and the mute button is hidden on my screen. Okay, make sure you can still hear me. Good. Okay. So progression can be seen via topography, refraction, or a change in the RGP back curve. These are the 3 criteria used by most insurances and the 3 criteria used clinically to determine whether someone needs cross-linking. 2020 vision or 2025 vision is not part of the insurance criteria, nor is it part of the progression criteria. But I mention this because if you have a patient who is a clean 2020, I think there's reason to have a slightly higher threshold to cross-linking. It's certainly a harder conversation if they're just refractively changing. I've cross-linked many eyes that see 20/20, but it's always with a little bit of extra trepidation. We always know that there's no such thing as a free lunch. Want to make sure that the risk is balancing the benefit, and so I really want to be even more confident there's progression when we're cross-linking an eye that has extremely good vision. Older patients can need cross-linking as well. You can see progression at any age, although it's less common. We must assess the visual changes in the context of other ocular disease. For example, increasing myopia might be myopic shift from cataract development. And there's post-refractive surgery ectasia, pellucid marginal degeneration. There's even off-label utilization for radial keratotomy surgery, especially if there's large diurnal variation, more than a diopter. Don't cross-link people who have poor visual potential. And some patients are considered too thin for cross-linking according to the official criteria. So if you're looking at only on-label indication, 400 microns, actually that was reduced to 350 recently, is the theoretical number. But I regularly cross-link people who are thinner than that. There's a variety of techniques we can use, including just using the dextrin-free riboflavin, which swells the cornea, using a contact lens-assisted corneal cross-linking, using a Bausch & Lomb Ultra Contact, which has no UV blocking to it, to give about 70 microns of bonus thickness to the cornea, or an epithelial island technique of leaving epithelium intact in the area of the thinnest part of the cornea, and depending on riboflavin, diffusing into it. With these approaches, I've cross-linked people safely who have minimum corneal thicknesses as little as 250 microns. These are, of course, people who are probably scleral lens dependent and getting a lot of benefit from the lenses that way. Let's go on to some cases. This is a 20-year-old female. She has mild keratoconus. Her current glasses have her seeing 20/80. Her best corrected acuity of spectacles was 20/40, and she was 20/20 in RGP. And in the bottom left of that screen map, you can see the topography with the classic inferior steepening. And then we've got our posterior map in the top right that shows some hot spots. This is her month 3. We actually were able to achieve 20/20 with a refraction. She's one of those lucky people that saw an improvement substantially in vision after keratoconus. These are her images. So a typical appearance at 1 month post-op with that anterior stromal haze to about 40% depth. That's the demarcation line showing where keratocytes were affected by cross-linking. And if you're co-managing one of these patients, you're likely to see this. Don't worry, this is not an inflammatory finding. And as we see here, it gets better on its own at month 3, and it was even better subsequently. Patient education should start with you. Remind our patients this is not refractive surgery. Contact lenses or spectacles will still be needed. The aim is to halt the progression. There is only one FDA-approved cross-linking drug device combination, and this is the only approach covered by insurance and covered by malpractice insurance carriers. So it's important to ask questions about how is the cross-linking being performed and letting your patients be aware that there's really only one solution in the United States right now that meets these criteria. Fortunately, essentially every commercial insurance now considers cross-linking medically necessary if there's room for progression. And so as a result, it's generally accessible to all patients who need it. There's also programs in place by many physicians, myself included, to provide care for indigent care patients. And Glaukos, the company that makes this system, has resources available to us that even will provide complementary treatments resources like the Photrexa drug for patients who qualify based on financial need if physicians participate in that program. It's vital that we have documentation of progression. The most helpful thing you can do to help your patient get access to this necessary care is provide your surgeon, when you refer them out, or provide information on previous refractions. If you have topographies, send those as well. The proven progression is the green light to getting cross-linking performed as quickly and as expediently as possible. If you're asking about what the cost is, remember that deductible, coinsurance, and copay are what come into play for our insured patients. But as a cash pay procedure, this looks like a lot of money. Most of it goes into the Photrexa drug itself. The total billing for a cash procedure for someone who does not qualify for financial need varies from $6,500 to $9,000 per eye. But most of my patients end up paying less than $500 total out of pocket once they take into account deductible, coinsurance, and things like that. Future horizons for cross-linking are very exciting, and they're focused on the epithelium-on techniques. To date, previous studies published in Europe showed less effect, less duration, and higher rates of progression. So historically, epithelium-off has not been very exciting to those of us who really want to provide the most excellent care to our patients. But there are some patients who have a good response and recovery is fast, so it's been an area of active investigation. It's not FDA approved at present. There's no insurance coverage at present. But future horizons are bright, as Glaukos has recently reported positive phase 3 results for their epithelium-on cross-linking system, Epioxa. And a competing company, Epion Therapeutics, is enrolling patients. Actually, I think has recently completed enrollment in patients for an FDA-sponsored or FDA approval trial for their proprietary system as well. The Glaukos system and the Epion system are the only systems that are under registered studies with the FDA. So if you ask someone is telling you they're doing a study and they're doing a study for cross-linking, ask, is the Epioxa trial or the Epion trial, Epion Therapeutics trial? And if it's neither of those, I would be concerned about that personally. Glaukos has reported these positive phase 3 results for Epioxa based on their novel drug formulation, which penetrates the epithelium of the cornea. Remember, I said that you have to do something clever, something sneaky to get the riboflavin past those tight junctions. They're also using a stronger ultraviolet irradiation protocol, and they're adding supplemental oxygen to enhance the cross-linking, since that occurs as a result of riboflavin plus oxygen in the room, and oxygen is sometimes a rate-limiting step. Let's talk about, in our last 15 or 20 minutes, the surgical options we have to work with the cornea. Topography-guided surface ablation, I've been performing for since its approval in the United States around, I think it was 2017. And I did a lot of it in the past, but I'm now recommending it for only about 5% of the keratoconus patients I see. That's because it has the most specific selection criteria. The goal is to reduce anterior aberrations and also directly address the refractive error. It's a great surgery, but I'm much more commonly recommending CAIRS, also called CTAC, which is the successor to INTEX. CARES allows improved spectacle corrected vision and soft contact lens options for mild to moderate keratoconus. And almost every keratoconic patient who's in that range is a candidate for that procedure. The big difference between them is that PRK is a subtractive procedure, CARES is an additive procedure, and that's why more patients are a candidate for it. Now, neither of these prevents a scleral lens. As we mentioned earlier, if the patient likes their scleral, maybe we don't do any sort of refractive surgery at all and we cross-link afterwards. We can do cross-linking with PRK in the same treatment session or in separate treatment sessions. There's some pluses and minuses between those two ideas, but either way, the goal is to improve their best corrected acuity with some uncorrected acuity improvement as well, and then lock in that improvement via cross-linking. I always tell these patients, our goal is to make you more successful in glasses. This is not LASIK. The patients who desire uncorrected and best corrected improvement in vision have failed or rejected contact lenses, have a spectral corrected acuity of 20, 40, or better, and their refraction makes sense with their topography, so it's in line with the topography. Those tend to be our topo-guided PRK patients these days. Otherwise, CARES is the better choice. If the patient already has good enough spectral corrected acuity, we're thinking about ICL if the patient just wants to get out of those glasses. And of course, they need an optically clear visual axis and plenty of space to work, preferably 500 microns or more. In the simultaneous model, we perform PRK, cross-linking afterwards. In the sequential model, we perform the cross-linking first and the PRK about a year later. I'm going to show a few example cases of this. Knowing that the PRK is going to treat the refraction, but the cross-linking is also going to change the refraction over time, we do an undertreatment of myopia, typically aiming for about a -1 to -150. Dr. Kanellopoulos was the originator of this idea of combined cross-linking and topography-guided PRK, and what he published as the Athens protocol with some very exciting results. I want to show you a couple of my results that are done via the Wavelight system using the Four Cities planning system, which is a vector mapping system that looks at how the topography is going to change as a result of the topo-guided treatment. This is a 41-year-old with moderate and progressive keratoconus, uncorrected 2060, best corrected 2025, and he underwent this ablation with the PRK in the topo-guided mode. As a result, we were able to achieve the topography on the right here, a huge reduction in both astigmatism and irregularity. He achieved 2030 uncorrected and 2020 spectral corrected with just a +50 sphere. Second case is a mild progressive keratoconic, 2070 uncorrected, 2040 with a plano -325 at 142. Here's the ablation that was performed. And here's the resulting topography. A year later, this patient is 2040 uncorrected, a 3-line improvement, and 2020 now best corrected with a much more manageable prescription as well. Life-changing differences. And one final case, proving that not all of these are slam dunks, but they can still be life-changing. A 24-year-old, 2400 uncorrected, 2080 spectacle corrected, unable to get a driver's license because of his vision. He's just unable to wear contacts at all. Did a topography-guided PRK combined with cross-linking. And as a result, we ultimately, let me back that up one slide and show this, improved him to uncorrected 2070 and spectral corrected 2040. He was now able to get a driver's license and be driving himself around Atlanta, hopefully not being a hazard on the roads, but certainly he could at least get that license. We're really excited for him. It's worth noting that the PRK ablation can actually be seen in the cornea long term. Look at that mid-peripheral haze from doing a really big 70 micron ablation in that zone. Not visually significant, but I thought it was interesting. Finances of PRK is it's refractive and not covered by insurance. So I'm going to briefly talk about Intact and spend my remaining time talking about CARES and CTAC. I'm sure many of you have seen Intact. It's been around for 20 plus years. It was an interesting procedure, but it also had fairly variable results. 1 or 2 rigid PMA segments are put inside the cornea for mild to moderate keratoconus, and these are pretty typical images afterwards with some reduction of higher order aberrations, improved uncorrected and best corrected acuity. One segment was used in many cases, usually aligned with the cone, could also use 2 segments in some cases. Here's a case of Intact. So this is a patient who underwent a single segment Intact intratemporally. And the 47-year-old male ultimately ended up getting to 2030 instead of 2040, where he started with this quick and easy procedure. That's pretty typical, a one-line improvement. Here's a more superb case, a 41-year-old who is 2100 in glasses, 2030 after intact segment. And then we did a toric ICL and actually got him to 2025 uncorrected and 2020 best corrected. However, there were downsides. Glare, risk of extrusion. It must be placed deep inside the cornea. So for most patients, we didn't get a very substantial effect. One, maybe two lines of acuity, maybe a 10 to 20% reduction in astigmatism at best in most cases. But their interest, corneal allogenic intrastromal ring segments, or CAIRS, also being marketed as CTAC. This is the most exciting new refractive procedure in the keratoconus space over the last several years. And the idea of doing a CAIRS procedure was first described by Susan Jacob several years ago. Involves a custom cut piece of corneal donor tissue. In the original described CAIRS tissue, this is made with a double trephine that makes this sort of thin donut ring that's then cut in half. This is then placed inside the cornea. Here's an image on the right side of one of these donor segments that's not yet inside the cornea. This is an image of one of my patients who underwent CAIRS, and you can see that ring of corneal tissue placed infratemporally, much like you'd place an intact segment in the same zone. This is a preoperative topography, 1 day postoperative, and this is the difference map, a 20 diopter difference in the apex of the cone, and a huge improvement in vision, quite possible as a result. This was the first CAIRS performed in Georgia. That's me doing the surgery, and you can see it on screen. Excuse me. For this first surgery, we stained the tissue very blue to make it more visible. I still don't do that. I don't still do that routinely. The patient was 2060 pre-op and 2030 with a 6.5 diopter reduction in astigmatism postoperatively. Obviously, a life-changing difference for this patient. So I want to show you the actual CAIRS procedure. This is a live surgery. I've not changed the timing on it. I've edited a few little pauses going from one thing to another, but otherwise it's completely live. I choose to do femtosecond assisted. So in the top right, you can see us applicating the cornea with the same laser that we use to make LASIK flaps. This is the LASIK FS200 or Alcon FS200. We are docking and then lining up the center of the cornea with a dot that I made using a purple marker at the slit lamp. I made two dots because the first time I missed a little bit. You'll see which dot we're actually lining up on is the more central of those two. And then we activate the laser and actually create a channel 360 degrees with an incision point that's been determined based on the patient's topography and based on their refraction. Now, the laser makes this ring with a set interior and exterior diameter, which we can customize, and makes an incision up to the surface that you see on the left side of the screen, which will be one of our entry points for accessing the ring. We then come under the bed moves to the other side of the room automatically, which is the laser we would use for excimer for LASIK. I make a second access point using a guarded diamond blade. So this blade is set so it can only go 500 microns deep, gives me access on the right side of the channel so I can both push and pull, as you'll see. I'm using a blunt dissector to open up the channel that was fashioned by the laser, and a second blunt dissector to open it up, essentially all the way around to where we're going to place the corneal segment, which has been prepared by the eye bank, so that it can slide in easily. I'm going to open this channel in both directions, so there's no tissue bridges. This is exactly the same idea as lifting a femtocreated LASIK flap, just with different shaped instruments. This is the corneal tissue. It's been prepared by the eye bank. This is a CAIRS tissue. With CAIRS tissue, it's made using a double manual trephine. With CTAC tissue, it's made using a femtosecond laser to custom parameters. This tissue I've inserted into the channel using tooth forceps. I'm using my other hand to sort of pin it in place while I withdraw the forceps, and then feed the corneal ring segment hand over hand down the channel. As I mentioned, this is a real-time surgery. This patient is under just topical anesthesia, drop of lidocaine. They've received 5 milligrams of Valium, just like we do for a LASIK procedure. So pushing that segment into place, and here's where we're going to choose to make use of the other access point. So I reach in with a curved Reverse Minsky hook. I'm under that segment. I'm pinning it up against the channel roof and then pulling it until it's into the desired orientation that we planned based on the patient's topography of refraction. Once this is complete, we'll smooth the segment out on the surface. Just make sure that there's no little folds in it, that it fills the channel neatly. This is a sutureless procedure, just like LASIK would be. The patient's going to go home the same day and the next day feel just fine, maybe just a little bit scratchy. It's a very minimally invasive experience and a very exciting one for the patients based on the result that I'm going to share with you. So the advantages of CAIRS over previous techniques that we've used include the 250 micron depth instead of the much more like 70 to 80% depth of intact, which gives us more topographic effect. There's minimal to no glare. It's biointegrated, so there's no risk of extrusion. It's fully reversible. We could reach into this channel months or even a year or two later and remove the segment if we have reason to do so. There's fast recovery and fast improvement. There's a return to contacts in 2 weeks if desired. And at low risk, these patients get very meaningful corrected vision improvements. The disadvantages include that it is donor tissue. There's a theoretical risk of rejection, although it's extremely rare. In my first 200 cases, I've seen one case of rejection, and it responded well to topical steroids. And it's not magic. It's not going to fix a very severe keratoconus and doesn't have perfectly consistent results. So we can't tell a patient for sure you're going to get this specific refractive result or this specific vision improvement. But I do quote to them the averages, which I'll share with you. It is covered by by most commercial insurances. We can do it in combination with crosslinking, and we'll often perform CARES first and then crosslinking follows in a month, although I'm also evaluating doing them in the other order this year. So I analyzed a year's worth of cases that had 1 month of follow-up and 2 months post-crosslinking if it was a combination. The improvement in uncorrected acuity was 3 lines of vision. The improvement in spectral corrected acuity was 2.5 lines of vision. And that ranged from no improvement, where a 2020 eye stayed there, a 2025 eye stayed there, and a count fingers eye proved that it wasn't magic, all the way up to a 10-line improvement. A 2400 patient who was 2400 best corrected in spectacles and contact lens intolerant was able to achieve 2040 after a successful CARES procedure. And the reduction in astigmatism is equally exciting. Nearly a 50% reduction in astigmatism on average, which means when patients have very asymmetric keratoconus, CARES can be a tool that we can use to reduce their anisometropia and make them much more successful in glasses if that aniso was the big barrier to them being able to wear glasses previously. I'm going to highlight a few cases with the last 2 minutes I have to share a talk with you, and then we'll be open to questions. This is a patient who was 2400 previously, saw only a small reduction in astigmatism, but achieved 2040 afterwards. And I'm showing you their pre and post format pentacams here. Here we have a patient who was 2060 with 425 of SIL. They achieved a significant reduction in both myopia and a reduction in astigmatism, like that 50% reduction, and we're seeing 2020 in glasses after CARES. Another patient who was 2070 prior to the procedure saw an increase in their astigmatism and kind of a bizarre move to being much more hyperopic afterwards. But I think this is just because that refraction before surgery was a 2070 soft endpoint, and now they're able to actually get us to the 2025 they're seeing at. This patient, of course, despite having a big change in their glasses prescription, was thrilled about the change. And one more, a patient who was 2070, very myopic, only a little bit of astigmatism, ends up much less myopic, a little increase in refractive astigmatism, but goes from 2070 to 2025 in glasses. Life-changing improvements with CARES. As I mentioned, CARES and CTAC are being used almost interchangeably at this point. CTAC refers specifically to when the tissue is produced by a corneogen, which is one eye bank, and it's being produced using a femtosecond laser, patient-specific laser cut tissue, rather than the one-size-fits-many that we've done with CARES tissue historically. I'm still exploring in my practice where CTAC is going to take us. We recently started doing both procedures. I do think it has the potential for even more refined outcomes. My early CTAC cases seem to have similar results to what I've seen with CARES, but the numbers are small on CTAC in my practice so far. Surgically, it's the exact same surgical technique. CTAC planning is actually very elegant. You send your pentacam images over to the company that is going to make the tissue with their femtosecond laser or cut the tissue, and they help you produce a nomogram-based plan like the one pictured here, which shows you the segment size, where you're going to place the segment, the diameter of the inner and outer ring, and the depth to place it based on the measurements given. Finally, don't forget toric ICLs and IOLs, which are very important tools. Sometimes patients have high spectral corrected astigmatism, but really what they just need is internal correction of that astigmatism to be pretty happy. So this is one of my favorite patients a while ago now, 2017, that she was uncorrected count fingers. She was 20/30 and 20/70 respectively, with very, very high astigmatism. We placed toric lenses during femtocataract surgery, really treating early cataract here because she only had trace cataract that wasn't a vision limiting cataract in either eye. And the result was that she ended up 20/20 in the right eye and much better in the left eye, uncorrected in 20/25, spectral corrected in the left eye, showing that when she was able to put a lot of that astigmatism internally, because it was such a regular central pattern, it could be a really big improvement for her in glasses as well. I'm actually going to skip over this last case. It's kind of a little bit more of the same. I'd rather leave time for your questions, but this is a sort of a discussion of toric lenses when they're good and toric lenses when they're not good, which is that we don't put toric lenses in irregular astigmatism. So obviously, many of you are tuning in from around the country, around the world, but if your patients want to come to Atlanta or if you're local to me, I'd love to work with you. If not, I would love to offer advice from afar. I hope this reaches many doctors as we continue to spread the good word about cross-linking CAIRS and topography-guided